meaningful use of an electronic medical record, which means a lot of things to a lot of people, and it's pretty ill-defined. But it pretty much boils down to clinicians with appropriate documentation, with physician order entry, with all the appropriate risks, risk safety things associated with that. And that's pretty much what the clinicians can provide as far as meaningful use. So PulseCheck actually gives us all of that in one package, and we've been doing that for the last 2 years, ever since we went live. I mean, I can pretty much say we can't do anything else to demonstrate meaningful use. It's pretty much all there, everything that we do.
Evidence-based medicine does make sense, and you have to, it's a fine line between cookbook medicine and telling a doctor how to practice, but the evidence-based order sets help you meet Joint Commission and core measure requirements, but they also help you not miss things that are kind of important in, say, an MI patient post-MI. But it also, I mean, it's the right thing to do for patient care, so that if our evidence shows that these patients that have this diagnosis should be sent home on a beta blocker, we're not missing that. And even though we had all these on paper, we didn't have perfect use of them, because you had to go find that particular order set, right? Now, PulseCheck, it's right there. There's no question about it.
I think Abington is in very good shape for meaningful use. I was reading the criteria, and I think we've met and very close to meeting quite a bit of it. So I'm not real worried that we will not be there when they want. At Abington, we'll be able to do it. We are, because I do think that we're a little ahead of the game going into it.
On the flip side, you want to talk about a meaningful use. What we've been talking about today, bringing clinical decision support to the point of care at that moment in time. Why isn't everybody doing this? I don't think organizations generally are ready for this. I think they would like to be. I think they're waking up. I think that they're seeing that the future is the kind of thing that we've worked on together between TSG and Picis. The work we did that we've done with PulseCheck over the last decade is called the risk mitigation module. It wasn't born out of traditional risk management. Traditional risk management is once there's an error and an adverse outcome, it's figure out the best way to deal with the claim, with the malpractice lawsuit. That's not how we think of risk management. I think these days, when we think of risk management, certainly the way I and the Sullivan Group think about risk management is we're not talking about doing the best thing we can with a claim. We're talking about there never being a claim. We're talking about the patient being the big winner because we figured out what the issue is beforehand.
St. Mary Medical Center has already shown that we are prepared for the days of meaningful use, and we could probably meet the requirements today. We've had an aggressive plan for house-wide physician order entry, but we've been live with PulseCheck for 5 years and doing ED physician order entries since we went live. And the interoperability pieces have been in the works for the last year to 18 months. So I think we're certainly prepared, and I think that we would have been down this road even without the funding that was going to be available from the federal government.